I learned the ugliest truth about medical appointments on a rainy Thursday, standing in a crowded hallway outside room 12. A grandmother named Frances had waited 6 weeks to see me. When I finally sat down, she smiled, folded her hands, and said, "I'm sorry to bother you, doctor. It's probably nothing." 10 minutes later, I learned it wasn't nothing at all. She had lost 10 pounds without trying. Her chest felt tight on stairs, and she had fainted once in her kitchen. But because she'd opened with an apology and softened every sentence, I almost missed the urgency hiding between her words. I still think about how close we came to walking past danger because of the way a good woman spoke. Before we go any further, let me say this clearly. This video is for educational purposes only and not medical advice. Use what you learn to prepare, then bring your voice, your strong, direct, honest voice, to your next visit. I want to hear you too. How old are you, and where are you watching from? Tell me in the comments. I read them like postcards from friends, and your stories help other women find their own voice. Today, I'm counting down the 10 communication mistakes I see older women make in clinics every day, from 10 to 1, each one wrapped in a real story, a simple piece of science, and a fix you can use immediately. And when we reach number 4, you'll see the habit I believe is the most dangerous of all because it hides life-threatening symptoms in plain sight. Let's begin. 10. Speaking softly and politely and getting dismissed. It feels natural, even gracious, to soften your voice and preface your concern with kindness. Many of you were raised to be modest, patient, and never make a fuss. But inside exam rooms, that softness can strip urgency from your symptoms. Research in patient education and counseling has shown that less assertive patient language correlates with fewer diagnostic tests and shorter doctor follow-ups, while a large observational study in the Journal of General Internal Medicine linked clear, firm statements to higher rates of action. We're not blaming manners, we're describing how tone shapes clinical decisions. Elaine is 72, a retired librarian who told her cardiology nurse, "It's probably nothing, but I've been a bit more tired." That sentence sounded like a breeze, not a storm. She left without labs. 2 months later, she returned pale and short of breath. Her hemoglobin was dangerously low. We treated her anemia and looked for causes, but the delay was born in the whisper. The fix is simple and strong. Lead with the hardest truth in a steady voice. "I'm unusually tired. I'm short of breath on stairs. I need tests today." Your kindness isn't the problem. Your voice deserves volume and weight when your body is asking for help. The next mistake is even more surprising because it isn't about volume at all. It's about how we shape the story itself. Number 9, using indirect language that hides the problem. When you say, "Sometimes I feel a little off," your doctor hears fog. When you say, "I have chest pressure every morning that lasts 10 minutes, your doctor hears a flare. Studies of clinical encounters in older adults, including analyses published in Patient Education and Counseling and Health Expectations, show that specific declarative sentences increase the likelihood of guideline-concordant testing. Vague phrasing lowers perceived severity, especially under time pressure. Gloria is 72, a widow who described little flutters and a touch of fatigue. Her physician assumed anxiety and sent her home. 2 weeks later, she arrived in the ER with a small heart attack. In tears, she told me, "If I had said I have chest pain every morning, I think they would have listened." The fix is precision. Speak in clear, time-stamped sentences. For 3 weeks, walking 1 block causes chest tightness for 5 minutes. Specifics force attention. Indirection invites dismissal. And if vague words can hide danger, the next mistake buries it even deeper by shrinking yourself with apologies before you've said a single symptom. Number 8, over-apologizing for taking up time. "I know you're busy. I'm sorry to bother you. It's probably not important." These are the little rugs we lay down so our concerns feel smaller, but data from sociolinguistic research and healthcare communication studies, including reviews in social science and medicine, show women, especially older women, apologize more in medical settings and are more likely to have their concerns categorized as non-urgent. Not because doctors don't care, but because time pressure makes us use subtle cues to triage what must happen now. Ruth is 76, a retired teacher with 3 weeks of chest tightness. She opened her visit with, "I know your time is precious." The appointment slid past the cliff edge without labs or an ECG. Days later, she was admitted with a non-ST elevation heart attack. She survived, but we both wished for a different first sentence. The fix is a swap. Replace apology with assertion. I need your help. I'm having chest tightness several times a week. You are never a burden for seeking care. Your presence is not a favor you're asking, it's a partnership you're leading. 7. Letting family members speak for you. Daughters and sons mean well, but when they dominate the conversation, your doctor loses the most important diagnostic tool we have: your own words, your own emphasis, your own face when pain is described. A report in Health Communication found that when companions overtake the visit, physicians ask fewer follow-up questions to the patient and miss symptom nuances. Older women already face bias. Outsourcing your voice compounds it. Lorraine is 75 and came with her daughter. When I asked what brought her in, her daughter answered, "She's fine, just tired." Lorraine nodded politely. Only in the hallway did she whisper to the nurse that her chest felt tight on mild exertion. A month later, she needed a stent for severe coronary disease, a story that might have been different if she had led the visit. The fix is choreography. You speak first in your words, your family adds details after. Say to your loved one beforehand, "Please let me go first, then fill in anything I miss." Support doesn't replace your voice, it strengthens it. If giving up the microphone can hide danger, the next mistake makes danger sound less urgent even when you hold a mic yourself. 6. Downplaying pain and calling it just age. I hear it every day. "It's not too bad, just old bones. I can live with it." But the body uses pain to shout. When we translate it into a whisper, care stalls. Studies in the Journal of Pain and the Annals of Emergency Medicine have documented gender differences in pain assessment and treatment, with women's pain more likely to be minimized. Add age to that equation, and under-evaluation becomes even more common. Evelyn is 74 and limped into clinic after months of hip pain that woke her at night. She told her doctor, "It's just a bit of ache." No imaging was ordered. By the time we scanned, the arthritis was advanced and her muscle had deconditioned from guarding the joint. She later said, "I thought not making a fuss was strong. Strength would have been stating the truth early." The fix is measurement. Give your pain a number and a function. It's an 8 out of 10 at night. I can't climb stairs or sleep. Numbers and impact create medical gravity. They also protect you from your own habit of minimizing what hurts. And if pain can be muted by habit, the next mistake cuts your story in pieces before the most important sentence ever arrives. 5. Accepting interruptions and losing the main thread. Under pressure, clinicians interrupt too often. Studies captured by JAMA and BMJ Open show that doctors frequently redirect patients within seconds. When you allow the redirection to stand, your key symptom can vanish from the agenda. Helen is 79 and began, "I've been feeling off," then described her diet, sleep, and garden. 10 minutes later, she finally mentioned daily dizziness. The moment had passed, the plan was vague. 2 weeks later, she collapsed from an arrhythmia. The science of time is brutal. An average primary care visit is brief, and once a visit's frame is set, returning to the initial problem is difficult. The fix is a boundary, spoken with kindness. I'll answer that, but first I need to finish my main concern. I get dizzy every day and I almost fell. Then pause. Hold the lane until the core problem is acknowledged and a plan is made. If interruption steals your main story, the next mistake erases the clues we need to interpret it correctly. 4. Forgetting a complete written list of medications and supplements. I cannot interpret dizziness, bruising, falls, or fatigue without knowing what's in your bloodstream. Polypharmacy is common after 65. CDC data show a large share of older adults take 5 or more prescriptions, and supplement use is widespread. Research in Journal of the American Geriatric Society and JAMA Network Open has shown frequent unreported over-the-counter products and herbals that meaningfully interact with prescriptions. Fish oil plus anticoagulants, ginseng plus diabetes meds, antihistamines plus sleep meds. The combinations change diagnosis. Maria is 78 and complained of profound fatigue. She listed her blood pressure medication but forgot her daily ginseng and fish oil. Her doctor reassured her. Weeks later, she landed in the hospital with a bleeding ulcer while on a blood thinner. The missing list hid the real story. The fix is preparation. Bring a written list of every prescription, dose, over-the-counter drug, vitamin, and herbal, or bring the bottles in a bag. Update it before each appointment. A complete list turns a guessing game into medicine. And even with the right list and the right words, the next mistake quietly lowers your authority with a smile. 3. Smiling through symptoms and masking distress. Women are taught to make others comfortable. I see patients smile while describing crushing fatigue, laugh softly while talking about bleeding, or brighten their voice to sound fine. Behavioral research in clinical communication, including work summarized in medical care, suggests clinicians unconsciously rate symptoms as less severe when nonverbal cues convey ease. It's not fair, and we must do better, but it's real. Janice is 70, a retired choir director who joked through her shortness of breath. Maybe I'm just out of practice. Her oxygen saturation dipped when she walked down the hall. I only caught up to the seriousness because a nurse noticed her lips blanch when she laughed. The alignment matters. Let your face and body match your words when something is wrong. It isn't about theatrics. It's about not hiding your distress. Say, I'm scared because I can't catch my breath, and allow the fear to be seen. Authenticity helps urgency land. If a smile can confuse our triage instincts, the next mistake is even more dangerous because it changes your data before you ever speak. 2. Arriving unprepared. No symptom timeline, no vital details. Clarity doesn't happen by accident. Studies in health services research show that preparation improves appointment outcomes. When you arrive without dates, triggers, or patterns, we spend your precious minutes mining for basics instead of acting. Preparation is power, not performance. Walter Retta is 73, a retired accountant who kept a little notebook in her purse. When her legs began to swell, she wrote the date it started, the time of day it worsened, and what helped. At her visit, she opened to the page and read, 3 weeks ago, swelling by evening, shortness of breath at night, gained 5 pounds. That timeline moved her straight to labs, a diuretic plan, and close follow-up. We caught heart failure early. The missing prep can cost you time. The fix is a 1-page prep. Right when it started, how often it happens, what makes it better or worse, and what you've already tried. Bring weight logs, blood pressure readings, glucose numbers if you have them. 10 minutes of preparation at home buys you 10 times the clarity in clinic. And all of that still won't matter if we stumble into the single ugliest trap of all, the one that turns red flags into secrets. 1. Hiding embarrassing symptoms. This is the habit that scares me most. Older women often conceal urinary leaks, bowel changes, vaginal bleeding, memory lapses, sexual pain, or falls because they feel ashamed or don't want to cause trouble. Studies in the Journal of Women's Health and qualitative work in BMC Geriatrics show that embarrassment delays disclosure and delays diagnosis, and delay worsens outcomes. Doctors can only treat what they know. Jean is 74 and came for fatigue. Near the end of the visit, she whispered that she'd had vaginal bleeding for months and was changing pads twice a day. She told no one. That disclosure changed everything. We found endometrial cancer, caught later than we wish, but still in time to treat.
She cried after surgery and said, "I thought being quiet was dignified." Dignity is telling the truth about your body so we can protect it. The fix is courage rehearsed at home. Say out loud, "I have bleeding. I am leaking urine. I am forgetting things. I fell." Practice the sentence until it can walk into the room with you. Nothing you say will shock a good clinician. Honesty is not impolite. It is life-saving. Here's what the science and stories add up to in one breath. Older women are too often dismissed, not because they lack symptoms, but because their symptoms arrive wrapped in softness, vagueness, apology, interruption, missing context, smiling nonverbals, thin preparation, and silence about the most private changes. These are not character flaws. They are learned survival skills from another era. But in medicine, they can cost you time, function, and sometimes life. The power is yours. Speak plainly and early. Claim the floor when you need it. Bring your medication list in your timeline. Let your face match your worry, and say the unsayable first. When you do, your words change what we test, how we treat, and what we save. Have you ever made one of these mistakes at a medical appointment? Tell me in the comments. How old are you and where are you watching from? Your story may be the one that gives another woman the sentence she needs to finally be heard. If this opened your eyes, like the video so more seniors see it, and subscribe for more science-based senior health tips. We're building a community where wisdom gets louder, not quieter, with age. I'm Dr. Sarah. Thank you for trusting me with your attention and with your voice.